3 days notes there. What's your good name, doc? Huh? Tulasi, good. So let us take up the next important topic, topic number 3 in ENT, which is facial nerve lesions. Evening 5 to 8 p.m. is a very tough time. If you worked in the hot sun in the hospital, this is the time where we wanted to stretch our legs and relax. But still, we'll make the session as much energetic as possible. This is little better than cramping ourselves on one full Sunday or full Saturday into a marathon session. Nothing registers, right? So, okay. And altogether, let me tell you, the notes given to you, if you just peruse and come, session become altogether more interesting. So that's the whole idea. Now, facial nerve, neuroanatomy, knowing it is all about the diagnosis and treatment. The questions basically come on neuroanatomy predominantly. Now, doc, where is the nucleus of the facial nerve? I am also your neuroanatomy teacher. Brainstem. We have medulla, pons, midbrain. 3rd, 4th, midbrain, 5, 6, 7 bones, 8, 9, 10, everything, cranial nuclei are located in the medulla. So in this, the lower part of the pons, where the pontomedullary junction is there, we have a nucleus for the facial nerve. Obviously, if our hand moves or leg moves, something in the precentral gyrus in the motor cortex will control. Even when we smile and our facial muscles contract, it is the motor cortex which will tell whom? The facial nerve nucleus in the pons, which in turn will control the facial muscle activity. Just like androgens in the spinal cord control the voluntary muscles, is what you need to remember. Now, if you look at this facial nucleus, it is typically being divided into two halves. The upper part of the nucleus will go and innervate our forehead muscles, and the upper half of the facial nerve nucleus has two mothers, because the father married twice. So the stepmother, own mother, both will control. So ipsilateral, contralateral, from both the sides, the cortico-bulbar fibers will come to the facial nerve nucleus and innervate the upper half. So that is the reason, if I have a stroke and my motor cortex, let us say, on the right side is gone, immediately what should happen? My left side facial nerve nucleus should get affected, and then what should I get? The left half of the face paralyzed. But it doesn't happen. The left upper half of my face is not paralyzed, because though my right motor cortex is ischemic, in fact, my left motor cortex is also supplying my left facial nerve nucleus, hence it won't be affected. Whereas if you look at the lower part of this nucleus, which goes and supplies the lower phase, typically it is only from the contralateral side only it will receive the corticobulbar fibers. Ipsilateral side it won't receive, the lower half. So that's the reason if I have an infarct there, my lower half of the face get paralyzed on the contralateral side, but my upper half of the face won't be affected because it is still receiving the fibers from the ipsilateral side. Agreed now? So that's the reason, what do you remember? UMN lesions of the facial nerve typically will spare the upper half on the contralateral side and only lead to lower half of the contralateral side get paralyzed. But if I get an infarct which is directly puncturing my facial nerve nucleus in the pons or the facial nerve itself when it is passing through, then that contains the fibers going to both upper half and lower half. Hence the entire half ipsilaterally will be gone. That means if my right facial nerve nucleus in the pons is gone or my right facial nerve is gone, then my entire right half of the face gets paralyzed. But if my right motor cortex is gone, my left lower half of the face only is paralyzed. But my left upper half of the face is spared. It is what we need to ultimately remember. Now doctor. Supranuclear lesions preserve the muscles of the forehead is what need to be remembered. Now comes another very important part which you need to remember. We are angry, we smile, we bite also sometimes our classmates and roommates. If we are really in such a bad canine temper, entrance नजदीक आ रहे, लेबर रूम पोस्टिंग्स है एक तरफ से, दूसरे तरफ से 15% और 10% पढ़ के MBBS में गोल्ड मेडल आ गया, अब कैसे फिलअप करना remaining 50% of 100 topics for the fast approaching entrance in November. So we have different forms of facial expressions. Who controls them? It is typically the emotional part of the facial nerve, facial muscles. They're all the ones which receives the fibers from thalamus. So that is the reason, doctor, whenever there is a supranuclear lesions, thalamus is not affected. Where is thalamus located? Below the cerebral cortex, na? Thalamus, hypothalamus and all those things. So that is the reason in upper motor neuron lesions the muscles controlling the facial emotion are unaffected. Whereas lower motor neuron palsy they are affected. Right, doc? So that's a whole difference. Now, let us quickly run through and walk through the neuroanatomical map of the facial nerve, which is a favorite question of the examiner. Facial nerve has one motor nucleus. What will it do, doctor? It will go down and goes and supplies the all facial muscles. Now what is the exception? All the muscles in the face receive the motor supply from the facial nerve except levator palpebrae superioris of the eyelid, which lifts the eyelid, is innervated by oculomotor nerve. Hence oculomotor nerve palsy leads to lid drop, ptosis. Then what else do we have? The laddu, bundi, mithai, jalebi which we eat, taste. There is a gustatory nucleus which is typically located in the nucleus tractus solitarius. Nucleus tractus solitarius is sensory or a motor nucleus? Sensory nucleus. Sensory nucleus for three common nerves. What are they? 9th, 10th, 7th. For all the three, sensory nucleus common hub is the solitary nucleus. In that we have the 7th cranial nerves. Taste fibers which are being brought will reach this place. From where are they coming? Let us track. Typically, afferents are all, these are all afferents, doctor. So, typically, the anterior 2/3 of the tongue, the taste will come down, 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 and it is going up. And this is basically called the chorda tympani. And typically, the chorda tympani comes, passes, reaches ultimately the gustatory nucleus in the nucleus tractus solitarius. Agreed? Then what else do you have? We are having the lacrimal and superior salivatory nuclei. Why they need to be remembered in relation to facial nerve? Because typically facial nerve also is responsible for carrying the fibers which will go to the submandibular ganglion and pterygopalatine ganglion. And from submandibular ganglion, the fibers will go and innervate the submandibular and sublingual salivary glands. And from the pterygopalatine, they go to the lacrimal gland and the nasal glands and typically supply the secretomotor fibers. Our tears are due to facial nerve. Our salivation which occur from the sublingual and submandibular salivary glands is from facial nerve. But who supplies parotid gland? Very good. Auriculotemporal, glossopharyngeal, otic ganglion, that is a different story. Lingual nerve, which we discussed in anatomy, no? Right. So, doc, having had this general mental picture first, remaining things you will understand in no time. Just to what is specially you need to learn about facial nerve in ENT, when it passes through the Tora Bora caves of the middle ear, what are its relationships? Already we discussed it in anatomy, you might have forgotten because it is 2 days now. So, we are having the birthright to forget. Now, typically, if you look at the facial nerve, the motor fibers will march and they basically hook around the abducens and they are joined by the sensory root. Who is the sensory root? Nucleus tractus solitarius. And from there they leave the brainstem and at the level of the pontomedullary junction, and they typically enter into the bony facial canal. They traverse to the temporal bone, ultimately come to stylomastoid foramen. From there they come out and supply the face. So, this is the typical course. So, obviously, how can you divide the clinical, anatomical course of the facial nerve into intracranial part? From where to where? From the pons until internal acoustic meatus, not external, internal acoustic meatus. It is 1.5 to 1.7 centimeters. Very small, doctor. You need a operating microscope for that. Then you have a infratemporal part. That is when it enters into the Tora Bora caves of the ear. From internal acoustic meatus to stylomastoid foramen. See, from internal acoustic meatus, doctor. Where is internal acoustic meatus typically located? At one of the ends of the middle ear. From there, it passes through the temporal bone and exits out between mastoid and styloid process called stylomastoid foramen. This particular course is called infratemporal course. Now it is being divided further into 4 parts. That part, when it is still in the meatus, you call meatal segment. It is around 8 to 10 millimeters. You have imagination, no? 10 millimeters is 1 centimeter, not 100 millimeters. Right? In our days, we used to put bets, 10 millimeters or 100 millimeters. How much is 1 centimeter? And then offer a cup of tea. When? Just 1 day before MD entrance. Because that time our mathematics is forgotten after reading 19 subjects in MBBS. Now, you have a labyrinthine segment from where to where. Typically, from the meatus until geniculate ganglion, you typically have what is called as the labyrinthine segment, and in this area it turns posteriorly. The other day we have studied, no, the middle ear is a 6 shaped box in anatomy, and common MCQ in the entrance. Between the 4 segments, which is the narrowest segment between meatal versus labyrinthine versus tympanic versus mastoid. Typically, it is the labyrinthine segment which is considered to be the narrowest segment and is what need to be remembered. Shortest segment is which one out of these 4 segments is another favorite question of the examiner. It is the labyrinthine segment, which is only 4 millimeters. Hence, any edema of this area where labyrinthine segment is there is often responsible for the development of lower motor neuron type of a facial nerve paralysis. Then you have a tympanic, which is called the horizontal segment. This part, doctor, that is from the geniculate ganglion to just above the pyramidal eminence. You call it as horizontal or a tympanic segment. Typically, it is this place where oval window and lateral semicircular canal, this segment is related. Okay, so this is about 11 millimeters. Then you have a vertical segment, that is from the pyramid to stylomastoid foramen, and in this area you have what is called another second turning. No, every turning is called one genu. This is one genu, this is one genu. Don't confuse between these 2 different genus. Right? So, second genu of this nerve it is. Then it is vertically down. Okay? Now, after coming out, it becomes extracranial and it typically lead to multiple branches. Which supply, what are the branches once it comes out? Temporal, mandibular, zygomatic, maxillary, cervical. All together is called as pes and serenus is what need to be remembered. Now, doctor, we come to the most high-yield part of the facial nerve, which is a frequent MCQ topic. What are the branches of the facial nerve? What do they supply? Any entrance you go, whether anatomy, neuroanatomy, neurology, or whether it is ENT, it's a common issue. Branch number 1, greater superficial petrosal nerve. Where do you see greater superficial petrosal nerve? Where is it given, doctor? It is typically arises from geniculate ganglion. Geniculate, you remember, no? In the infratemporal course, after internal acoustic meatus, second railway station is geniculate ganglion. Until the segment between the 2 is called labyrinthine segment. Okay. So, it arises from the geniculate ganglion, the greater superficial petrosal nerve. You can see this is the geniculate ganglion, doctor. Once more, let us start from here. What do you have here? The various motor and sensory nuclei. Together they pass it through internal meatus, and after that they typically reach the geniculate ganglion. From this, the greater superficial petrosal nerve has started, and it carries the secretomotor fibers that go to lacrimal gland and to the glands of the nasal mucosa. These are the 2 things which come from the greater superficial petrosal nerve is what you need to remember. Then, second important nerve in the infratemporal course, nerve to stapedius. It arises from at the level of the second genu. Where is second genu? When the horizontal segment becomes vertical segment, there you have second turning, no, of the steering. So that is called second genu. There it supplies, see this is the horizontal segment becoming vertical segment and comes out through stylomastoid foramen. Here it gives rise to nerve to stapedius, which will go and supply the stapedius muscle. So this is an example of nerve to stapedius. Nerve to stapedius, this one. And this is the stapes, whose foot is abutting which window? Oval window. So this stapedius muscle is the one which is innervated by the nerve to stapedius. Any injury to this nerve will lead to hyperacusis is what need to be remembered. Then the third important branch, chordae tympani. which we already discussed in anatomy. Typically from where does it arise? This vertical segment is there, no? In the middle of this vertical segment, just when it is coming out of styloid mastoid foramen, chorda tympani will arise. Okay, now, chorda tympani should not be remembered down, it should be remembered up. It is carrying the taste fibers coming from the tongue, anterior 2/3. Okay. So how does this chorda tympani basically will pass? It passes between incus and neck of malleus. Between the two, this chorda tympani will be typically passing during its course through the middle ear. Then it leaves the tympanic cavity through the pituotympanic fissure, and it has the secretomotor fibers which are coming from, it carries the secretomotor fibers to submandibular sublingual glands, and it brings the taste to from the anterior 2/3 of the tongue. So you can remember, doctor, typically when the facial nerve is passing down vertically, it gives rise to this chorda tympani, and typically this chorda tympani is bringing the taste from the anterior 2/3 of the tongue and secretomotor fibers of the sublingual and submandibular glands, and during its course it will be passing between incus and neck of malleus. They are the main points. Then one more, branch number 4. It is called communicating branch, which is the branch between 7th and 10th. So it joins the auricular branch of the vagus, and ultimately it will supply the concha, retroauricular area, posterior meatus, and the outer surface of the tympanic membrane. They're all the areas which are being supplied. Then you have one posterior auricular nerve. Why you need to remember? Because the occipital belly of occipitofrontalis, etc., they're all through posterior auricular nerve. Then what are the other muscles? Stylohyoid and posterior belly of the digastric, you need to remember. This digastric is a dirty fellow. He has one anterior belly supplied by 5th cranial nerve. Posterior belly is supplied by 7th. Why it happened like that? Because embryologically it has derived from 1st and 2nd branchial pouches. That's the reason. So now, doctor, what is the blood supply of the facial nerve? It has got a very, very long course. Naturally, it eats food at lot of places. Anterior inferior cerebellar artery, which is the branch of vertebral or basilar or posterior cerebral. Circle of Willis, 100% you should be sure, doctor. Huh? So then labyrinthine artery, which is the branch of inferior cerebellar artery, anterior inferior cerebellar artery supplies when it is passing through internal auditory canal. Superficial petrosal, which is the branch of the middle meningeal artery, will be supplying it typically between geniculate ganglion and the surrounding area. Ultimately, the stylomastoid artery, which is the branch of the posterior auricular artery, is the one which supplies the mastoid segment, is what need to be remembered. Now, doctor, I know by now your cerebral edema must have built so much that high time to go to quiz. But before that, let us finish 2-3 important aspects of facial nerve so that we get that confidence we finished a complex subject. Bell's palsy. 60 to 70% of the facial nerve palsies are all Bell's. By very nature, it is idiopathic. It is a peripheral palsy, hence it is element type. It is of acute onset. Both men and women, equal frequency it will affect. With the increasing age, increasing chance of getting belled. And a positive family history in about 6 to 8% of people. And certain subsets have got increased risk of bells. Diabetics, pregnant women, they are the ones who have an increased risk. Now, doctor, when there is a Bell's palsy, what is the rule? The entire half of the face typically get affected. So what will that lead to? There is typically droopy eyelid, dry eye, and excessive tears. Of course, this figure and that figure are on the not on the same side, so don't get confused. Then there is drooping of the mouth. So this side it is drooping, this side no. So there you should imagine facial nerve palsy onto this side. Now, what is the etiology? Some say viral, herpes simplex virus, herpes zoster, Epstein-Barr virus. You need to remember. There is a vascular theory about ischemia when the long course of the facial nerve is receiving blood supply from multiple places. Heredity, some people have a narrow fallopian canal through which the infratemporal course of the facial nerve has to cruise, which makes it vulnerable, and some say autoimmune. Now what are the important clinical features, doc, that you need to remember? Sudden onset, unable to close the eyes, Bell's phenomenon. What do you mean by Bell's phenomenon? You ask the guy to close the eye, then the eyeball will turn up and out. Is basically called Bell's phenomena. Is a very, very classical feature. Saliva will be dribbling from the angle of the mouth. Face become asymmetrical, and the tears will be flowing down. Epiphora will be there, and in few people there can be a pain as a prodromal symptom, pain in the ear, which can accompany or precede the onset of the nerve palsy. Due to the stapedial paralysis, there is a hyperacusis, which is a classical feature. Due to chorotympany involvement, loss of taste, and there can be complete or incomplete paralysis, and about 3 to 10% of people there can be a recurrences of the Bell's palsy, are the important buzzwords that you need to remember. So how do you evaluate? Nerve excitability tests are typically done to monitor the typical degeneration of the nerve. One of the common MCQs in the exam. Which diagnostic tests have a role in facial nerve palsy management? So, since the eyelid cannot close, the cornea is continuously exposed, there is exposure keratitis risk. Then there is some role for the physiotherapy and massage of the facial muscles. At least it will give a psychological support to the patient, so it doesn't influence the recovery. Now comes a $1 million MCQ in the entrance. Do you like to give steroids? Will it have any role in Bell's palsy? Examiner will drag your feet into quagmire of confusion in the exam. What is your confident no? It is a no, which you have to confidently say no. So their steroids, their utility is not being proved. Is not being proved, some studies say good, some studies say bad. If at all you give, prednisolone need to be given, and a good number of studies say not much of role. Now, how do you want to manage a case of Bell's palsy? You give prednisolone, ask the patient to come down on 5th day. If the paralysis is recovering or incomplete, dose is tapered during the next 5 days. If the paralysis remains complete, then the same dose is continued for another 10 days and thereafter tapered in the next 5 days, which is considered to be the management total of 20 days. Then giving steroids, some studies have shown has a beneficial effect for certain effects of Bell's palsy. What are they? Synkinesis, crocodile tears, recovery time being shortened. There are few advantages of giving the steroids a little early. And suppose you are suspecting herpes zoster underlying cause, then you can combine steroids along with the acyclovir. But ultimately, what is the surgical treatment of the? You need to do the decompression of the nerve and relieve the pressure. is considered to be the very important part of the treatment. Now, doctor, what are the causes for the recurrent facial palsy? Is a common MCQ in the exam. Bell's palsy, 3 to 10% of cases, recurrent facial palsy. Melkerson's syndrome, we will take up one of the MCQs on this. Diabetes, sarcoidosis tumors, they can lead to recurrent. Then one more common question. Bilateral facial paralysis, what are the common causes? Guillain-Barré, sarcoidosis, sickle cell, acute leukemia, bulbar palsy, they can lead to bilateral facial paralysis is what need to be remembered. In this context, you need to know Ramsay-Hunt syndrome. What is meant by herpes zoster oticus? Very simple. In this, there is a facial palsy. Along with that, there is a vesicular rash, as what you can see here in the external auditory canal or pinna, makes it Ramsay-Hunt. And they can also have anesthesia of the face, hearing impairment, associated features, because even 5th and 8th nerves also can become concomitantly involved. So, doctor, Bell's palsy, Ramsay-Hunt are very important. Now comes one peculiar topic. The topic we don't read still pass MBBS exams. What is that? Facial palsy and temporal bone fractures. You have to be 100% sure on this very important topic. I'll make it easy. Very few points that you need to remember. Why temporal bone and facial nerve? Because infratemporal course we have seen temporal bone and the facial nerve are closely related to each other. They go together to the school. Temporal bone, when it fractures, transverse or vertical, two ways, but most commonly in about 50% of people it is a transverse fracture. And after a temporal bone fracture, immediately if the patient has got paralysis, then you need to treat it conservatively, just like Bell's palsy. Give steroid, give reassurance, give etc. etc. Immediate fractures. Delayed fractures. If it is an immediate fracture, temporal bone fracture, 7 o'clock, 8 o'clock, you have seen patient and you already discovered facial palsy. Then that becomes an indication for decompression. Anastomosis of the remaining part, cut ends, that's what you need to do. And you need to do nerve grafting. Now this is an example. This is a typical CT. This side the temporal bone mastoid, okay. This side mastoid, okay, but what happened to the temporal bone? There is a fracture. We are talking about this fracture which can affect the facial nerve. Now doc, longitudinal versus the transverse fractures, what are the main differences? So, yes, here there is a small tricky point. Let me tell you, it's not transverse more common. Longitudinal are more common, but between longitudinal transverse, facial nerve palsy is more common in transverse fracture. One small pass pointing, right doc? Transverse fractures may 50% of times facial nerve involvement is seen. But overall between transverse and longitudinal, if you take 80% of fractures of the temporal bone are all longitudinal, where facial nerve is less commonly involved. Then what type of injury? If the parietal bone is hit, then that lead to longitudinal, whereas occipital will lead to transverse. Then bleeding from the ear is absent in transverse but more often seen in longitudinal. CSF rhinorrhea is more often seen in longitudinal. And the cranial nerve 7 and labyrinth, they can get injured in transverse more often than longitudinal, whereas the ossicular dislocation and tympanic membrane injury, they are more likely in the longitudinal. and sensory neural form of deafness is more common in the transverse, and vertigo is more common because of the injury to the labyrinth in case of transverse. Facial paralysis is more commonly seen in the case of transverse, 50%, but only 20% in case of longitudinal. Even when it is seen, it is of a delayed onset in longitudinal, which can be conservatively managed. But in transverse, more commonly it is seen immediately, which need to be surgically decompressed. So they are the main differences. You need to be 100% sure on this table, because this is one of the favorite questions of the examiner. Now, doctor, any systemic diseases, facial palsy is more common? Yes, sir. Diabetes, hypothyroidism, leukemia, sarcoidosis, polyarteritis nodosa, where there can be vasculitis and ischemia to the facial nerve. They are all some of the systemic diseases, including leprosy, etc., etc. Now comes the challenging part. Not challenging. If you know anatomy, you can easily answer this. In this long course of facial nerve, how will you localize the injury? Where is the injury? Based on the clinical presentation of the patient. In which cases there is a sparing of certain nerves, in which cases there is involvement. So that's very common. So doc, start from the central pons. Why pons can become ischemic? Strokes, brainstem strokes, cerebrovascular accident. How will you know it is affected at the level of the pons? I mean, not even pons. Above the level of the pons, corticobulbar fibers between motor cortex and pons. Lower half of face on the contralateral side with the sparing of the upper half of the face. Emotional movements are not involved. Points towards central facial palsy above the level of the pons from corticobulbar fibers. Then all muscles are involved if the nucleus or the facial nerve is involved. Then in its course, it can be involved in cerebellopontine angle because of an acoustic neuroma, which is our next topic. Then not only 7th, 5th and 8th also get involved because they are all passing through the cerebellopontine angle. That's an important clue. Now in the infratemporal course, we do the Schremer's test. What is Schremer's test, doctor? We check the lacrimation on the two sides, and is there any decreased lacrimation? If the decreased lacrimation is there, means what does it indicate? That the lesion is proximal to the geniculate ganglion. Okay? You know, no? Internal acoustic meatus to geniculate ganglion to the end of the horizontal segment, then becomes the vertical segment. That's what we studied, no? Right. So the secretomotor fibers to the lacrimal gland leave at the geniculate ganglion via the greater superficial petrosal nerve. That's the reason any decreased lacrimation indicates that the lesion is proximal to the geniculate ganglion, is what we basically conclude. Then stapedial reflex. So nerve to stapedius and chorda tympani, from which part will they arise? Vertical segment, no? You have meatal, labyrinthine, horizontal, vertical. Am I right? That's what we discussed. Right. So stapedial reflex is involved, means above the level where the stapedial nerve to stapedius is arising. So we basically use the tympanometry in order to test the stapedial reflex. Then taste. If the impairment of taste is there, means along the vertical segment, just when it is about to exit the stylomastoid foramen, chorda tympani is arising, no? That means there is an interruption above the level where the chorda tympani is arising from the vertical segment. If there is an impairment of taste, then broadly lesions are divided into, these are all the lesions there. proximal to geniculate, distal to geniculate, above the level of nerve to stapedius, below the level, and above the level of the chorda tympanis origin from the vertical segment. Now, doctor, yes. Hence, we can divide the lesions into suprageniculate, suprastapedial, infrastapedial, another way of calling it, and infrachorda tympanis origin. Suppose if you are doing a parotid surgery injured, where does the lesion fall into? Infrachorda tympani. Taste is not affected, stapedius is not affected, secretomotor fibers are not affected, nothing is affected if the facial nerve is injured peripherally after it left the stylomastoid foramen. So you have what, doctor? Infracaudal means after chorda tympani arises from the vertical segment, before it is exiting the stylomastoid foramen. Agreed? So that only facial motor function is affected. Infrastapedial means between the origin of chorda tympani and the origin of nerve to stapedius. So there is a loss of taste but preservation of stapedial reflex. Suprastapedial means between the geniculate ganglion and the nerve to stapedius के बीच में. There is a loss of stapedial reflex and taste, but still preservation of lacrimation. And suppose if the lesion is arising above the level of the geniculate ganglion, then there is also loss of lacrimation. Okay, doc? For everything, who is the Brahma, Vishnu, Maheshwar and Saraswati? Which table you need to do, which illustration you should never forget in your lifetime, doctor? Let me go up and once more reinforce to you. This is the important, I think it has gone long back because it was all in the initial anatomy, right? Okay. So this is all about the localization, doctor. Now, what are the complications after the facial paralysis? Before we say goodbye to this topic, I am very happy all our 100+ students across country did not run away and still holding their patience before we go to quiz. When the person eats food, आंखों से tears निकलेगा. इसको बोलते हैं crocodile tears. And why does it basically happen? Because of a faulty regeneration of the parasympathetic fibers, which typically supply lacrimal gland instead of going to salivary glands. At eating time, salivary glands are expected to stimulate, but lacrimals are basically stimulated. So how can you treat that? Favorite MCQ in the exam. Greater superficial petrosal nerve is there, no? Usko cut karo. That's the treatment of choice. Then what is Freiss syndrome? There is a sweating and flushing of the skin over the parotid area at the time of mastication, which can occur because of the parotid surgery and once more abnormal reinnervation of auriculotemporal nerve to the overlying skin. Then finally, we need to know one small entity called hemifacial spasm. You may say, why are you obsessed about this topic? This was the most recent topic in the recent state entrance, 2013 AP. Repeated uncontrollable twitching of the facial muscles is called hemifacial spasm. It is idiopathic, secondary, acoustic neuroma, or a congenital cholesteatoma, or glomus tumor. Anything can be responsible. Mainly, what is the reason? This is the question asked. Most common underlying cause for the hemifacial spasm is what? Was the MCQ in the 2013 state MD entrance. It is the irritation of the nerve because of a vascular loop at the cerebellopontine angle which is irritating it, lead to facial spasm. And you treat it by doing microvascular decompression and posterior fossa craniotomy. And we also can give botulinum toxin is considered to be the management. Peace in the world. So doc, after going home, what will you do? Facial nerve palsy, laryngeal cancer, and the 20 pages of notes we have given for the anatomy, Now how much of homework is left over? 20 plus 20, 40 pages. Every day we will be charging you with 20-25 pages of content. At the end of 145 days in 29 weeks, Monday to Friday, 3000 pages we will try to drill into your brain, high yield topics and facts. Once you cleared this 1200 topics, and how many pages? 20 into 145, 3000 pages, doctor. 85 to 80% of paper. Like a skating, you must be able to answer. Still 20% of paper require common sense, which you never read. Probably your clinical experience in housemanship. They will help you in the remaining 20%. Still, why people get seat? Not due to their inability to answer the 20%. It is their mistakes done in this 80% standard part is responsible for a lot of failures in the exam. So be very sure. 2 minutes will be out of video to take a backup, and then we will have a quiz. Following that, we will have one more topic to say goodbye. Yeah. Please stay on.